Good afternoon. Welcome to the National Combined Grand Round on COVID-19 being held by the All Indian Institute of Medical Sciences in collaboration with Niti Aayog. This is the fifth National Grand Round that we're having, and I'm delighted to welcome you all to this Grand Round. Today we'll be actually focusing on the extrapulmonary manifestation of COVID-19. We've been now almost 8 months through COVID-19, and there's a lot that we've learned, and our strategy has changed dramatically from what we thought about COVID-19 in January or February of this year. From what we thought of a simple viral pneumonia has a lot of other manifestations which are beyond the lung. And as we've sort of known more and more about COVID-19, we realize that it causes many extrapulmonary manifestations. And this is basically because of the fact this virus enters into the cell through ACE2 receptors, and these ACE2 receptors, although abundant in the upper airways and in the lung, are also present in many organs, and therefore there is effect as far as these organs are concerned. Also, it has a lot of other effects which cause hypercoagulable state, it causes a cytokine storm, and therefore there are a large number of manifestations that we are now observing which are beyond the lung. And therefore we thought it's very important that we discuss the extrapulmonary manifestation, because we've seen many patients who presented with features which have been not predominantly pulmonary but extrapulmonary. Pulmonary manifestation continue to dominate as far as the majority of cases of COVID-19 are concerned, but there is a significant number of patients who would present with manifestations which may be along with pulmonary manifestation or maybe without pulmonary manifestation. And therefore, we as clinicians need to have a high index of suspicion during this pandemic as to when to suspect, treat and isolate these patients so that we can provide them good quality care. So really, to discuss this whole topic today, I have a very esteemed panel. I have Dr. Padma, who is the Professor and Head of Neurology and the Chief of the CN Center at the All Indian Institute of Medical Sciences, New Delhi. We also have a guest who's awake in the middle of the night, Dr. Uma Malhotra. She's a Clinical Associate Professor, University of Washington, Seattle. She's an AIIMS graduate who was trained in both infectious disease and immunology, and is a PI on a number of COVID treatment trials, as well as a clinical PI for the COVID Immunology Research Program at her institute. Welcome, Dr. Uma Malhotra, and thank you very much for staying awake in the middle of the night to be part of this National Combined Grand Round. Thank you.
Thank you very much. Thank you very much.
We also have Dr. Ambuj Roy, who's Professor of Cardiology at AIIMS, New Delhi, and Dr. Neeraj Nishchal, who's Associate Professor of Medicine at AIIMS, New Delhi. To begin with, we will have a presentation of two cases. One would be on the neurological manifestation, a very interesting case which will highlight the neurological manifestation that one can see as far as COVID-19 is concerned. And this would be followed by another very interesting case from the Department of Cardiology on the cardiology manifestation, which will be presented by two of our faculty. The neurology case will be presented by Dr. Ayush Agarwal, who is Assistant Professor in Neurology, and the cardiac manifestation by Dr. Deepti, who is an Assistant Professor in Cardiology. And after that, we will have a brief presentation by Dr. Neeraj on the extrapulmonary manifestation of COVID-19. So to start the show, let's have Dr. Ayush Agarwal, who will present the first case on the neurological manifestation, followed by Dr. Deepti, who will then present the second case. Dr. Ayush from Neurology.
Thank you, sir. A left thalamic bleed. Thank you. Good afternoon and very warm welcome to one and all present here. I'd be speaking on stroke and COVID-19 on the behalf of Department of Neurology at All India Institute of Medical Sciences, New Delhi. I directly start with a case that we saw in our emergency. He was a 35-year-old male patient who presented with no previous comorbidities and had sudden onset right hemiparesis with loss of consciousness for the past 12 hours. He had no preceding headache, no history of similar complaints in the past, no vomiting, no cardiac disease, and he was asymptomatic for COVID-19. On examination, he was afebrile, his GCS was E1B1M5, and he was intubated in the emergency in view of poor sensorium. His blood pressures at presentation were around 180 by 100 millimeters of mercury, and a pulse rate was 90 per minute, regular in rate, rhythm, and character. His respiratory rate was around 20 per minute, and he had dense right hemiplegia. An emergent non-contrast CT head done revealed the presence of a left thalamic bleed with an intraventricular extension with an ICH score of 3 with a midline shift around 2 to 3 millimeters, and a CT chest which was done as a part of the green stroke pathway in accordance with the Indian Stroke Association guidelines revealed the presence of bilateral ground glass opacities which are most predominant in the posterior basal subpleural region. And also, RT-PCR was sent for COVID-19, which is the institute protocol prior to admission for all patients. And pending the investigations, we also started our emergency management, which was CNS decongestants in the form of mannitol, a broad-spectrum antibiotic in the form of ceftriaxone. Injection labetalol was given for control of blood pressure, STAT, and an SOS basis. A neurosurgery consultation was taken, but we were advised against an active intervention, and the patient was Riles tube was inserted and a Foley's catheter was inserted. Not surprisingly, the patient came out to be COVID positive, following which he was shifted to trauma center, which is the COVID designated center at All India Institute of Medical Sciences. After admission to the trauma center, we found that the patient had a difficult to control blood pressure, and progressively we had to add 4 to 5 antihypertensives to bring his blood pressures down. This aggressive management was done because for a patient of an intracerebral hemorrhage, we need to bring down the blood pressures, systolic blood pressures to below 140 millimeters of mercury, as trials have shown that higher blood pressures are associated with hematoma expansion and poorer outcomes. Vitamin C and zinc were added in lieu of the COVID management protocols. Repeat CT scans done in the trauma center revealed a decrease in the midline shift as well as some resolution of the intracerebral hematoma. And as you can see, during admission for the first few days, the patient had a normal hemogram, had normal renal and liver parameters, and ECG revealed a left ventricular hypertrophy, and an echo also revealed the same with an ejection fraction of 55%, which is indicative that the patient probably had a long-standing hypertension, which was till now undiagnosed and undetected. Around the 5th day of admission, the patient started mounting fever, following which we shifted the patient from the broad-spectrum antibiotic in the form of ceftriaxone to a piperacillin tazobactam, and mannitol was tapered and stopped since the hematoma and the associated edema was decreasing. Oral drugs were continued, and the patient also underwent an ultrasound abdomen because we wanted to rule out a renal parenchymal disease, which is the most common cause of hypertension in young individuals. We did not find any evidence of the same. An X-ray done on the 1st and the 3rd show marked changes. The X-ray done on the 3rd shows the presence of patchy consolidation seen bilaterally, which is more prominent on the right as compared to the left, which might be a manifestation of a viral pneumonitis or an ARDS. The day on which the patient mounted fever, we can see that the TLC also increased to around 15,000, thereafter normalizing during the next week. The renal as well as the hepatic parameters continued to be normal, and there was no evidence of any coagulopathy in the patient. This is the X-ray that we did on the 9th, and the hospital course from the 8th August onwards was better. The patient started to improve. He regained his M6 status. His hemiparesis also improved. We gave him a TP's trial on the 8th, which he tolerated well, which was followed by a room air trial the next day, followed by extubation. The patient was discharged on oral drugs, and we plan to do a detailed workup for his hypertension in a young individual once he's done with this quarantine period post-discharge. After having discussed the case, I want to emphasize on the neurological manifestations of COVID-19 and the pathophysiology of the same. So the proposed pathophysiology is twofold, one being the retrograde transmission of the virus through the olfactory epithelium, because it is said that the virus through the nose can reach through the cribriform plate, infects the olfactory epithelium, since it does not have a dural covering. And the other pathophysiology being that after infecting the lungs through the viremia, they cross the blood-brain barrier and enter into the CNS. Both of these mechanisms eventually lead to binding to the ACE2 receptors, as has been discussed by Professor Guleria, thereafter leading to manifold manifestations. The reasons, as I've discussed, finally coming to why does a stroke occur in COVID-19, the reasons again can be manifold, the most common being the endothelial damage. Once the virus particles reach the endothelium of the blood vessels of the central nervous system, there's a host immune reaction, which finally leads to a microangiopathy causing thrombosis and stroke. These can be further delineated from a D-dimer or a raised CRP levels, which are supportive for the same. In case that the viral load is high, the damage to the blood vessel may be even more profound, which can lead to a vasculitis form of injury, which is also seen in cases of varicella zoster. The inflammatory processes per se can also predispose to a procoagulant state and may also destabilize a carotid plaque, trigger atrial fibrillation or a myocarditis, eventually causing cardioembolic stroke. Coagulopathy and cytokine storms are prevalent and most commonly seen in the second week of infection with COVID-19 and can lead to both an ischemic and a hemorrhagic stroke. And finally, the final point that I want to emphasize, because the patient that I discussed with was an ICH patient, it is said that ACE2 receptors are eventually responsible for managing the blood pressure in any individual, and patients with hypertension have lesser ACE2 receptor levels. In case of a COVID-19 infection, the spike protein of the COVID-19 tends to bind to ACE2, further decreasing their levels, leading to an uncontrolled hypertension, which can manifest as an ICH. So to summarize, a SARS-CoV-2 infection can present with a direct CNS or PNS involvement, which can lead to a meningoencephalitis type of a picture, anosmia, ageusia, muscular injury. It can also cause a systemic injury, which can lead to a multi-organ failure presenting with a hypoxic ischemic encephalopathy, can present with coagulopathy, which can cause a stroke, can cause an inflammation, an inflammatory encephalopathy or an Kawasaki type encephalitis picture, and a post-infectious sequelae like a GBS or an ADEM. Some studies on stroke and COVID have come through, the first being by Li et al. From Wuhan in China, where they had studied 219 patients, out of which only 11 patients had a stroke. Similar study from Wuhan, China found out that only 6 patients had a stroke. Other studies from the United States have showed a lesser incidence of strokes, being 1.6 and 0.9%. And finally, some case series that have come through from the Italy and UK describing 4 and 6 cases of ischemic strokes and 2 cases of hemorrhagic strokes that have come through. What I want to emphasize is that all previous studies have shown that the strokes tend to happen only in patients who have severe SARS-CoV-2 infections, and these patients tend to be older and have multiple vascular risk factors. And they describe probable association when SARS-CoV-2 is positive and there's no other risk factor that is found, whereas possible association when there's SARS-CoV-2 and other vascular risk factors like a diabetes or a hypertension. So, but what we have found in our institute in the past few months of COVID-2 infection is a little different from the West, such that our stroke admissions did come down between March to May, which was expected because of the lockdown with people not wanting to come to the hospital for fear of SARS-CoV-2. But the mean age of admission of our COVID patients and stroke patients was actually lesser as compared to the time before SARS-CoV-2 hit. We came down to 54 years compared to 67. And an ICH percent went up by 15%. From a quarter, 25%, we went to 40% patients who had an ICH. And we would also like to highlight that despite the SARS-CoV-2 pandemic going on, our thrombolysis and thrombectomy rates did not go down. Anybody who came to our emergency in the golden hour of stroke treatment did undergo whatever was needed. So that brings us to the question that the patient that I described initially, was it only related to hypertension, or was SARS-CoV-2 also involved? Was it just associated and just found, or was it causative as well? Because it is hard to just deny the fact that our admissions for ICH went up from 25 to 40% because it is more severe and would tend to present. Further studies are ongoing to delineate whether it is an association or causation. Finally, coming to the number of COVID positive strokes that we've seen in the past 6 months, we've had 31 so far, 17 being ischemic, 13 being hemorrhagic, and 1 being a cerebral venous sinus thrombosis. Another thing that we found different is that all 31 of these patients were asymptomatic and minimally symptomatic for the pulmonary manifestations, And none of them actually had COVID pneumonia when we admitted them. It is only later that they developed it or they did not develop it at all. 2 patients developed stroke during hospitalization. One was on CKD and one was a malignancy. All others did present with the stroke. Thank you.
Thank you, Ayush. So now we will move on to the next presentation by Dr. Deepti about the cardiological manifestation, the case study, cardiology and COVID.
Good afternoon, everyone. I'll be discussing about the cardiovascular manifestations of COVID-19 infection. To begin with, COVID-19 infection, it has been proposed only that it can lead to a variety of potentially serious cardiac manifestations. Since the onset of this outbreak, a lot of papers have detailed the presence of myocardial injury in patients with COVID-19 infection. This has been defined as an increase in troponin levels in these patients. Myocardial injury can be either due to acute myocardial ischemia or due to non-ischemic injury in the form of myocarditis. Another interesting observation has been a substantial increase in the number of out-of-hospital cardiac arrests to the tune of around 58%. This has correlated with the cumulative incidence of COVID infection cases since that period. There has been an increase in the incidence of venous thromboembolism in these patients. In the pediatric population, a Kawasaki-like coronary arteritis has been described with multisystem involvement. This was discussed in our last grand round as well. Last but not the least, uncommonly, some of the patients with COVID-19 can present with disturbances of cardiac rhythm. In the first presentation, we have already seen a case of vascular involvement in COVID-19. We will be discussing a patient with COVID-19 infection who presented with a cardiac conduction disturbance. Our patient is a 50 years old lady. She has no significant past medical history. She presented with multiple episodes of pre-syncope for the last 3 days. These episodes used to happen at rest and were not associated with postural changes or exertion. She also complained of non-exertional palpitations, which she perceived as missed beats. There was no associated chest pain or dyspnea. She was not on any drugs prior to this presentation. Interestingly, there were no symptoms suggestive of an influenza-like illness at the presentation in the form of fever, cough, or coryza. On examination in the emergency room, she was found to have significant bradycardia. The pulse rate was 35 per minute and irregular. She had a blood pressure of 120 by 74 millimeters of mercury, respiratory rate of 18 per minute, and a saturation of 97%. She was afebrile at presentation. Chest and cardiovascular examination were within normal limits. To evaluate the bradycardia, an ECG was done. The ECG showed bradycardia with absence of P waves. As can be seen here, none of the 6 QRS complexes are preceded by any P wave, and there is this long pause between the third and the fourth beat. Thus, a diagnosis of sinus node dysfunction was made with the presence of sinus arrest, junctional escape complexes, and a sinus pause of 3.4 seconds. To evaluate for structural heart disease, an echocardiogram was done, which showed normal walls, normal chambers. Biventricular systolic function was normal. Serum troponin was also normal. Thus, there was no evidence of any overt myocarditis in this patient. The chest radiograph was also concurrent with the echocardiogram findings with no cardiomegaly. Her investigations were unremarkable except for the presence of anemia, which was microcytic and hypochromic and subsequently found to be due to iron deficiency. Renal function, liver function, and electrolytes were within normal limits. She was screened for COVID-19 infection in the emergency, and RT-PCR for SARS-CoV-2 was found to be positive. Her inflammatory markers in the form of IL-6 and procalcitonin were elevated. When she was received in the emergency, in view of bradycardia, she was started on dopamine infusion. Temporary pacing was not required as the heart rates improved after initiation of dopamine to more than 45 per minute, and she remained hemodynamically stable throughout. After RT-PCR came positive, she was shifted to a COVID-designated hospital where she received doxycycline, ivermectin, antibiotics, low molecular weight heparin, vitamin C, and zinc. Over the course of her hospital stay, there was a gradual improvement in the heart rate as can be seen in this table. This is the ECG done on day 4. Though sinus bradycardia is still present with a heart rate of 45 per minute, there were no further pauses and no junctional complexes were observed. She remained asymptomatic throughout the hospital stay. There were no symptoms of COVID-19 per se during this hospital stay. This is the ECG at discharge, which is showing normal sinus rhythm with a heart rate of 65 per minute. Post-discharge, she remained asymptomatic. She was re-evaluated 20 days after that with a Holter examination. This is the heart rate trend, which is showing a mean heart rate of 65 per minute. No sinus pauses were observed in the 24-hour recording. There was no suggestion of chronotropic incompetence, as can be seen in this ECG. Similar cases of de novo sinus node dysfunction have been described in 4 cases since the onset of the outbreak. Most of these patients were above the age of 65 years, except for one, a young 34-year-old patient in whom the sinus node dysfunction was described. All but one patient had comorbid conditions in the form of hypertension, hypothyroidism, or obstructive sleep apnea, all of which predisposed to sick sinus syndrome. In one of these cases, sinus node dysfunction was attributed to the administration of lopinavir-ritonavir, and there was resolution or discontinuation of the drug. There was spontaneous improvement in 2 patients and not requiring pacing. In one patient, sinus node dysfunction persisted, requiring dual chamber pacemaker implantation at the time of discharge. In none of these patients, there was any overt evidence of myocarditis. Similar to sinus node dysfunction, there have been 12 reports of cases with AV conduction abnormalities. However, in most of these cases, the primary presentation was complete heart block with an incidental finding of COVID-19 positivity. In only 5 cases, patients presented with a normal baseline sinus rhythm and went on to develop de novo AV conduction abnormalities in the form of AV blocks during the course of the illness. In our experience, over the last 3 months, we have seen 3 patients with complete heart block in whom pacemaker implantation needed to be done. None of these patients were symptomatic for COVID, and they were found to be incidentally positive for SARS-CoV-2 on screening. Regarding the pathophysiologic mechanism, some observations can be extrapolated from the SARS outbreak of 2002-2003. In vitro studies had demonstrated that the receptor responsible for viral uptake into the host cells was angiotensin converting enzyme 2, that is ACE2 receptor. These receptors are abundant in human heart. In transgenic mice in animal studies, this upregulation of these receptors was associated with increased severity of conduction disease. In human observational studies during that epidemic in 2002, significant sinus bradycardia occurred in 15% of patients with a mean heart rate of 43 per minute and an average duration of 2.6 days. Now here, with the novel coronavirus also, ACE2 receptor is the viral receptor for uptake into host cells. So it has been speculated that myocardial inflammation or direct viral infiltration via these receptors can affect myocardial conduction, leading to impaired chronotropic response and conduction system disease. But all said and done, I would also like to highlight the fact that there has been an actual paradoxical decline in acute coronary syndromes across several countries. Several reports from the US, UK, France, and Italy have reported that ACS incidence has actually come down since the onset of the outbreak. And this cannot be merely attributed to the underreporting of cases. So this needs to be kept in mind as well. In conclusion, cardiovascular involvement in COVID-19 infection may manifest in the form of myocardial injury, acute coronary syndromes, myocarditis, and arrhythmias. The conduction disturbances can be associated with COVID-19 infection irrespective of the severity of the disease and myocardial involvement. This is an uncommon association and should be kept in mind while managing COVID patients with bradyarrhythmias. The effect seems to be self-limiting. However, long-term follow-up studies can help to identify the natural course in such patients. Thank you.
Thank you very much for these two interesting cases. I'm really grateful to Dr. Agarwal and Dr. Deepti for these two interesting cases. We have a panel of experts. I'll just ask two brief questions and then we'll have the topic discussion, after which we'll open it up for questions and comments. One interesting point which Dr. Deepti actually highlighted was that ACS incidence has come down, and this is something which is of great interest in the cardiology fraternity, because there is a belief that is it related to our change in diet, that we've now stopped eating outside and having a lot of our home-based diet. Is it related to other factors which were related to the effect of COVID, or is it just a lower reporting? So I'm going to ask Ambuj to really comment on this as to, is there a real decrease in acute coronary syndrome during the last 6 months because of COVID-19?
Yeah, thank you, sir. It's a very interesting point, and I think it's a bit of all the points that you said. We have also observed that number of patients coming to ACS in our emergencies have dropped, and this is, as Deepti had presented, an observation across the world. Yes, it could be that people with milder symptoms or milder strokes are not coming to the emergency, but I think there is more to it. One of the risk factors, if you see for CVD, the top risk factor is air pollution. And clearly that has, in the last 6 months, if you see, dropped dramatically, for example, in Delhi, and that could have a large population level impact. So even if the impact is small, since it's affecting lots of people, that as a trigger has come down. So one could be that. Stress levels probably have come down because, driving in Delhi, for example, is itself stressful. So those stress factors could have come down. And of course, some bit of underreporting. So I think there's a lot of these factors put together which are responsible for this observation. We just wanted to bring out that aspect in our presentation and not just be, just one aspect of COVID causing a lot of cardiovascular disease, but the paradoxical decline.
So I think it's interesting because although we're discussing the manifestation, this is some sort of an observation which has been there across the globe. And one of the other factors has been related to air pollution also. So one will have to really tease out what are the factors that acute coronary syndrome has come down globally during the last 6 months. I don't think that's happened that much as far as strokes are concerned. Maybe Dr. Padma can comment on that if there's any observation.
Similar trends had been observed even for stroke. That in fact they said that acute ischemic stroke incidence fell down to almost, like thrombolysis rate fell down to 40% and endovascular treatment fell down to 60% globally. And then they've seen a peculiar trend of actually a rise once this COVID sort of was settling. And so again, multiple factors, but a lot of it has been attributed to underreporting in terms of inability to reach, as well as the infrastructure which was able to deal with these as well strokes when they would try and go, and then this fear of even reaching out. But all the other factors that Dr. Ambuj has also enumerated probably contributed. But what we've actually now seeing is a trend towards an increase in strokes. So it seems to be like a rebound, and even that's what we are seeing even in AIIMS, that now we are on average, we are seeing almost 4 to 7 strokes every single day, which actually fell down to just couple of strokes in 4-5 months immediately once we started with our pandemic.
So interesting observation. Let's see how the next few months pan out in terms of the cardiac and neurological manifestation, not only of COVID-19, but overall the presentation as acute coronary syndromes or stroke. How does that have an effect looking at multiple parameters? Remember, the pandemic has created not only issues which are related to the virus itself, but even other issues which are social, cultural, environment related, and that will have an impact on health in general. So we will continue our discussion, and the focus, of course, is on extrapulmonary manifestation. So we'll focus on that. Before we go to the presentation by Dr. Neeraj Nishchal, I'll just like to remind everyone that if you have any questions, please send them to WhatsApp. The number is 9999692364. It's being flashed at the lower part of the screen also. I'll repeat that again, 9999692364. Please send your questions, and we'll have the panel try and answer all your questions at the end of the talk. And now I invite Dr. Neeraj Nishchal to present his talk on extrapulmonary manifestation in COVID-19.
Thank you, sir. In spite of being with us for almost over 8 months, COVID-19 is still an enigma. What started as a viral pneumonia is now considered to be a multisystemic disease with capacity to affect virtually each and every organ of the body. Now the question is, what makes COVID-19 involve so many organs? So let's try to go through the basic pathophysiology of the disease. Now this SARS-CoV-2 have spike protein which is activated by transmembrane protein protease serine 2 and activates that, which then attaches to angiotensin 2 receptors, which is basically expressed in almost all part of the body with high preponderance in the GI tract, especially the small intestine, the kidneys, the male urogenital system, the heart, lung, and blood vascular supply. So it has propensity to in fact affect almost all body organs. Once it is inside the body, the virus replicates and can have various mechanisms of doing damage to various parts of the body. So it can have a direct cytotoxic effect, or by down regulating ACE2 receptors, it dysregulates the RAS system and thereby shifting the pathway towards angiotensin 2 predominant pathway, leading to inflammation, vasoconstriction, increased vascular permeability, and tissue injury. It can also cause endothelial damage, leading to decreased fibrinolysis and thrombin production. And this is the basic pathophysiology which causes various micro thrombotic and embolic complications. One important mechanism which SARS-CoV-2 has is that it inhibits the interferon signaling system, which is the main defense mechanism against the viral infections, thereby causing hyperactive immunity, leading to what we know as cytokine release syndrome, which can be very threatening and can cause multi-organ dysfunction. So the various extra pulmonary manifestation which has been associated with COVID-19 ranges from simple myalgias and anosmia type of thing to life-threatening encephalopathy, Guillain-Barré syndrome, thromboembolic complications, or sudden cardiac arrest because of arrhythmias and all. So almost all organs have some or the other manifestation attributed to COVID-19 disease. So I will share some data which have been, it's an interim analysis of data from one of the COVID wards for last 35 days. So out of 122 patients admitted in those wards, 53% of them have symptoms which was extrapulmonary without any obvious pulmonary involvement. So out of these patients, 75% had one or the other comorbidities along with associated conditions like pregnancy, and around 25% had no comorbidities at the time of admission. The common hematological manifestation described in literature for COVID-19 includes lymphopenia, which may be seen in as high as 90% of the patients, leukocytosis with neutrophilia, or thrombocytopenia. They have been thought to be a predictive marker in many studies. So what we have seen in our cases that around 24% had leukopenia, 25% had around leukocytosis. This thrombocytopenia of some degree was present in more than half of the patients, with severe thrombocytopenia in the 21% of the patients. When we further analyzed, we realized that the patient without any underlying comorbidity, 50% of them had thrombocytopenia, and around 27% of them had severe thrombocytopenia. However, these thrombocytopenia were not associated with any adverse outcome, and they resolved on their own without any specific treatment. We also saw some familial clustering. This specific family of 5 people had thrombocytopenia at the time of presentation, and this thrombocytopenia was not related to severity of the disease which the members presented. All of them recovered without any specific intervention. So whether this thrombocytopenia is just chance finding without any prognostic factor, just as we see in dengue, is again a matter of debate and needs further studies. Coagulopathy is again a hallmark of this COVID-19, and we tend to see elevated D-dimer and fibrin degradation products along with prolongation of PT and APTT. Venous thromboembolism and pulmonary embolism increases in these patients, and these have been thought to be cause of many sudden deaths in these patients. Thrombosis can be venous, arterial, or catheter-related thrombosis. In our experience, we have over last 1 month in our ward, we have seen around 9 patients with bleeding manifestation, which range from simple petechiae to life-threatening intracranial bleed. Thrombosis again was seen in 5 of the patients. Prolonged PT and APTT was seen in approximately 30% of the patients. So I will just share few cases which involve the coagulation defects in these patients. So this was 43-year-old female who was diabetic, presented with right forefoot pain with pregangrenous change. Now CT angio suggested non-visualization of lower limb arteries beyond popliteal artery. This patient was asymptomatic for COVID and was incidentally detected. This patient was managed as any case of acute limb ischemia with heparin infusion and other supportive measures, and the patient responded to the treatment. Another 41-year-old male who had no prior comorbidities presented with headache and vomiting. CT was suggestive of superior sagittal venous sinus and right transverse sinus thrombosis. So a diagnosis of cortical vein thrombosis was made, and patient was managed as per the existing protocol for any patient with CVT, and he responded to the treatment. What I want to highlight is that both these patients were labeled as asymptomatic for COVID, as they had no pulmonary involvement at the time of presentation. So the question arises, were they actually asymptomatic for COVID, or they should have been, since they had limb-threatening condition and life-threatening CVT, should they have been labeled as symptomatic severe COVID? So again, that needs to be discussed, whether we are actually doing justice with the classification. This elevated D-dimer levels have been used to guide anticoagulation, whether we have to use a prophylactic dose or therapeutic dose. So we usually use, in all symptomatic patients admitted with us, we start with low molecular weight heparin, unless there is a contraindication to that. And decision is based on whether the patient requires a therapeutic or a prophylactic dose, depends on the status of the patients. Prolonged PT and APTT are not considered a contraindication for starting low molecular weight heparin if required. Inflammation is again another hallmark of this disease, and this COVID-19, the SARS-CoV-2 is different from other common respiratory virus in that the other common respiratory virus, there is high interferon signaling pathway is not affected, so interferon is able to control the virus. But in COVID-19, this interferon signaling pathway is affected, and the immune system gets out of control, leading to activation of all sort of immune response and leading to inflammation. So this inflammation is depicted by increased levels of CRP, IL-6, ferritin, and other inflammatory markers. If a patient develops high-grade fever, hypotension, and has evidence of multi-organ dysfunction, we should always suspect cytokine release syndrome, or cytokine storm we commonly call it. So in our experience, we have seen that all asymptomatic patients without comorbidities, their IL-6, ferritin, and CRP were normal. But asymptomatic patients, if they had comorbidities, their inflammatory markers were raised at the baseline. So again, this gives a question whether how should we interpret these results. So if a patient who is otherwise asymptomatic but has raised interleukin or other inflammatory markers, the decision for using medications like IL-6 inhibitors should depend on the overall picture of the patient and not just the inflammatory markers. So this has a very important therapeutic implication. Steroids may be considered in patients who have severe to moderate disease and requiring oxygen. This will help in helping in the control of the inflammatory response which the patient body has mounted. The cardiovascular manifestation has been discussed by the previous speaker, but I'll just highlight 2 important cases which we had come across in last 1 month. This was 27-year-old female with RST with prosthetic double wall replacement. She presented with shortness of breath. So echo was done which suggested stuck mitral valve, and patient was managed accordingly. But again, this patient was labeled as a mild COVID disease because she hardly had any respiratory complaint, but this was a life-threatening situation. So again, should we refer her to just a mild COVID disease or a severe COVID disease? That again a matter of discussion. Similarly, a 57-year-old diabetic male, he had severe COVID, and at the time of presentation he had normal ECG, but 5 days into the course of hospital stay, he developed asymptomatic bradycardia, and in fact pulse rate came below 40. All the cardiac markers and echo was normal, and this bradycardia resolved on its own in next 20 to 48 hours. So again, these type of manifestation again related with COVID, or it's just something which happened because of some other reason, is again a matter of debate. We should not discontinue ACE inhibitors and ARVs because there have been numerous confusion whether this ACE inhibitors and ARVs should be continued in such patients or not. But current evidence is against discontinuation of ACE inhibitors and ARV. Baseline ECG should be done in all patients, and whatever cardiovascular complication happens, that should be managed as per existing guidelines for non-COVID patients. There is nothing extra that needs to be done in this patient except managing them in COVID designated area to protect the spread of infection in healthcare workers. Neurological manifestations have been discussed by previous speaker. So I'll just highlight two important cases, which again, this 31-year-old male who had presented with diarrhea of 1 week, which was followed by progressive ataxia and slowness of speech. NCCT head was normal. This patient was clinically diagnosed as a case of post-viral cerebellar ataxia. He was just managed conservatively, and over next 2 weeks he improved. And follow-up MRI did not reveal anything, but again, since this was associated with COVID, we assumed that this could be a manifestation of extrapulmonary manifestation of COVID. Another 12-year-old female who presented with painless loss of vision in right eye with weakness in the left leg and left upper limb. A diagnosis of neuromyelitis optica was made. Now she was labeled as asymptomatic COVID as she was tested just as a routine workup. She was treated with IVIG and methylpred, and she responded to the treatment. So again, these were labeled as asymptomatic and mild COVID disease, but this could have easily been a life-threatening condition. So question remains, are we ignoring the extrapulmonary manifestation of COVID? This 18-year-old female who had RSD with post-AVR, again she presented with left-sided weakness, and CT was suggestive of right MCA infarct with midline shift. She was managed as a case of acute ischemic stroke, and she responded to our treatment and was discharged in stable condition. So seeing these cases, we know we did nothing extra for this patient except managing as per existing guidelines. But we have to consider delaying dosing of immunomodulators in case if it is required in such patient, as this may cause complications in COVID-19 patients. GI manifestations have been described, which include nausea, vomiting, abdominal pain, anorexia, diarrhea, and also elevated liver enzymes. So in our group of patients, approximately 15% patient presented with nausea and vomiting, and around 6% patient had diarrhea, which was watery type, small bowel type, and without blood and mucus in them. ALT, AST in non-CLD patients were elevated in around 25% of the patients. BIL was elevated in 11% of the patient, which was predominantly unconjugated hyperbilirubinemia. There was no evidence of hemolysis in such patients. The literature suggests that predominant bilirubinemia in such patient is usually conjugated, but in our case we have seen unconjugated hyperbilirubinemia. All of these patients have ALT, AST less than 500. None of them had more than this. So this 15-year-old male without any comorbidities who had some pulmonary symptoms presented with pain, abdomen and vomiting for 4 days. His initial amylase level was slightly raised, but it did not fall within the diagnostic criteria of pancreatitis. But because of pain abdomen, we got his CT done, and it suggested a bulky pancreas, mainly the tail region with peripancreatic collection. So a diagnosis of pancreatitis was made, and patient was managed symptomatically. So COVID-19 can present with GI manifestations solely, diarrhea being one of the most common presentation. Renal manifestation in such patients may depend on the vascular coagulation defect in such patients, or because of cytokine elevation, or because of the direct toxicity on the proximal tubular cells and podocytes of the kidney, or because if patient is admitted in ICU, multiple other factors may affect the kidney functions. So acute kidney has been described in almost 30% of the patient in various studies. Proteinuria can be seen in almost 87% in critically ill patients, with hematuria in about 50%. The commonest electrolyte disturbance described have been hyperkalemia and metabolic acidosis. It has been reported that there is high chances of mortality in end-stage renal disease and renal transplant patients. So over last 1 month, we have seen 17 CKD patients with and 3 post-renal transplant patients. Acute kidney injury in patients without CKD was seen in around 14% of the patients, and hyponatremia was the commonest electrolyte imbalance which we saw in our patients. So we should routinely do urine routine and protein creatinine ratio at the time of admission. Serial renal function test throughout admission to monitor the kidney function test, and empiric anticoagulation, especially in those receiving renal replacement therapy, should be considered. In post-renal transplant patient, we usually discontinue anti-proliferatory drugs like mycophenolate. Steroids should be continued, and if required, it should be increased in doses. The calcineurin inhibitor dose is reduced by 50% in those requiring oxygen, and those who develop ARDS, in them, the calcineurin inhibitor is discontinued. Other manifestations may include hyperglycemia in previously normoglycemic patients, dermatologic manifestation, which could be simple maculopapular rash to what is described as COVID toes. We had one interesting case of skin manifestation which in a 43-year-old patient who had diabetes and stage 3 CKD. He had fever for 5 days and started with rash over the body, which was initially reddish, but over the time it developed into full-blown erythroderma. So this was managed conservatively. We reviewed his drugs, but we didn't find any offending drugs. So a possibility of COVID-induced erythroderma was kept, and the patient responded to topical steroids. Again, a reproductive health, as I have shown in the previous slides, that the male genital system have high expression of ACE2 receptors. So the previous outbreak of SARS autopsy series have shown that patient may develop viral orchitis. A study of 81 male patients in COVID-19 showed significantly reduced testosterone to LH ratio, suggesting potential hypogonadism. Now, does this translate into a long-term complication in a patient of COVID? That is something which needs to be seen and may have important implication in reproductive health of patients, young patients mainly, the male patients, that needs to be further evaluated and seen. COVID-19 is not known to negatively affect pregnancy, and all the pregnancy outcomes at our center has been okay so far. After seeing all these cases which I discussed, the question remains, is COVID-19 actually special in extrapulmonary manifestations? We have other viral infection which may cause many extrapulmonary manifestation, multisystemic manifestation, dengue being the most common, which we face in our part of the world. Is COVID-19 a precipitating factor or just an innocent bystander found at wrong place at wrong time? So that is something which we have to ponder, we have to find what exactly is happening. So for that, we need to compare with background rate of disease from the pre-COVID area. So association causation is still something which we need to work on. So I will conclude by saying that SARS-CoV-2 has potential to affect almost all organs, but whether it does so is still a matter of debate. Extrapulmonary manifestation of COVID-19 must be managed as per the existing guidelines based on other etiologies, and it needs no other extra strategy except managing in a COVID-designated area. Extrapulmonary manifestations should reflect in the severity classification of COVID, as sometimes, like I just showed the patient who had life-threatening complication, but he was labeled as asymptomatic COVID. So that needs to be revisited. Thank you.
Thank you very much, Neeraj, for this excellent overview. And as you see, that there's been extensive coverage of the extrapulmonary manifestation, which are beyond just cardiac and neurological. We have a large number of questions, and some are related to the case and some are related to general questions. I'll start by asking Dr. Uma Malhotra, who's been patiently there all the way in Seattle, and then from the panelist here. So Dr. Uma, there are two questions which have come up. One is, and maybe you tell us, do you use anticoagulants in all your positive patients, or when do you consider using anticoagulants in COVID-19 patients, and when do you use steroids, and when, what do you think is, what is the duration of steroids that you use, whether it's dexamethasone or methylprednisolone?
Okay, great questions. Great questions. So I'm going to start with the question on steroids. And I think steroids have really been the biggest game changer here. And we will use steroids in patients who are either on some form of supplemental oxygen, or they are on ventilators. So those are the groups where we have seen the most survival benefit. And so one group to stay away from steroid use would be not requiring oxygen, because the data have shown that there may be actually worse survival in those patients. And so survival benefit is about, I believe, about 32% who are on ventilators, and about 16% patients who are on supplemental oxygen. And the standard dose that we use is dexamethasone milligrams, either oral or IV, for 10 days until patient is ready for discharge. And so there is not a lot of data on other steroid formulations, but it may be okay if you did not have access to the dexamethasone to use another steroid such as prednisone or solumedrol. Are you able to hear me okay?
Yes, we can hear you. Please continue.
Okay. And the second part to the question about use of anticoagulants, and I think that is really key to management, because early, in the pandemic, when it was not so well, the knowledge was not so well founded, we saw patients who would be waking up, from being on the ventilator, and we'll notice that they have a stroke. So certainly, the severe critically ill patients, depending on their D-dimer levels and comorbid risks, we will decide what the level of anticoagulation in terms of, intermediate or more enhanced or usual. And patients on the floors who are there with moderate illness, we will just use the standard prophylactic dose, and no anticoagulants, for patients who are treated on an ambulatory basis.
Thank you very much. I think the message is very clear that when you're looking at steroids or anticoagulants, it is not meant for individuals who have mild illness or asymptomatic. The utility is more for moderate to severe disease, and there it's been shown to be really benefit. Steroids actually, and as part of the recovery trial, were harmful in the group of patients who were having mild illness who were almost asymptomatic. So I think the very important take-home message for all of the listeners here is, don't start steroids just like that on day 1 or day 2. You need to give it only in those patients who are having fall in oxygen saturation and who have moderate illness or going to for moderate to severe illness. So that, I think, is what Dr. Umar has also been trying to highlight, and the same holds true as far as anticoagulants are concerned. I have 2 questions actually for Dr. Padma. One is the reason for the loss of taste and smell. Why does it happen? How long can it last? And can it happen without pulmonary manifestations? And did all stroke patients that you saw have a normal chest X-ray?
Again, great questions again. So the ageusia or loss of taste is along with anosmia or loss of smell. Initially in the first flu screen, anosmia came out as a significant thing, and they found it almost like 15 to 20% that they were seeing this, and this was without any other flu manifestations in terms of fever, sore throat or cough or chills or myalgia. And ageusia alone also has been described very well now, and it is said that it is part of the peripheral nervous system involvement of COVID, and part of ageusia is also related to anosmia. When you don't smell, you don't taste it as well. And in ageusia, how long does it last has also been seen, and now we have literature to say that it may last for almost a couple of months. It does improve on its own. There's a lot of retraining that is being done. as a part of a, some kind of a therapy that you retrain to get your taste back. There were some literature on short course of steroids that doesn't have any level of evidence to say that you can take it. It does improve, it takes a couple of months. But that's part of the peripheral nervous system involvement of COVID. It's well established. In fact, we have it in our flu screen that an isolated agutia can also be a pointer towards COVID disease. The second question was, what about this CT chest? Now, as part of our stroke management, including the guidelines that we have now, which is endorsed by the Indian Stroke Association, a plain CT scan for all strokes. Immediately, we also do a plain CT chest. That's part and parcel of it. In fact, in most of the other places where there is not much of infrastructure available for immediate COVID testing, and this was a constraint a few months ago in many parts of the country, the CT chest along with the plain CT scan, which remains the workhorse for the diagnosis of acute stroke, became mandatory, and it's part of the guidelines. The reason is that we sometimes do pick up the lesions which suggest, and the patient may actually not complain, and he may remain asymptomatic. The caregivers may not complain because a lot of times these strokes can't even speak when they have a stroke coming to us. Now, how many of our stroke patients had this CT chest normal? Most of them, yes. Most of them actually had a CT chest normal. The case that we presented incidentally did pick up certain CT lesions. This was one odd case. In fact, I think I won't be able to give you the exact number, but predominantly we didn't have a CT chest abnormality at the time when they presented to the ER with an acute stroke, whether it was ischemic or a bleed. But this is part of our stroke diagnostic profile. We do that, and it's part of the national guidelines as well.
Thank you very much. Another observation that some of us have had, which I don't know whether I can say that it's something which is true, is that when you have patients who present with features of loss of taste or loss of smell, usually they have a milder disease. I don't know whether we can say that, but this is an observation that we've had, that most of our patients who've complained of this have not gone on to have a severe disease. So it sometimes just suggests, but we need more data as far as this is concerned. I'll move on to Dr. Ambuj. One question regarding the case itself: why dopamine was used and why did we not give atropine as far as this patient was concerned? And how common is atrial fibrillation as far as a cardiac complication of COVID-19 is concerned?
Yeah, they're excellent questions. So, for coming to addressing why we gave dopamine, atropine effects are very short lasting, and you have to give a more sustained response. We use dopamine infusion. Obviously, in normal times, we would have straight away gone for pacing, temporary pacemaker insertion in such patients, till the time we saw that either it reversed or would need an intervention in terms of a permanent pacemaker. But here, the patient on a very low dose dopamine did respond, had a good chronotropic response. So we continued the infusion, and beyond, after about 24 to 36 hours, she picked up and was hemodynamically stable, and it was discontinued and did need a TPI backup. So normally we would have gone straight away for a TPI in such kind of patient. The second question about atrial fibrillation, as you would aware, sir, most of the patients with pulmonary disease are prone to atrial fibrillation. And most of these sick patients, again, have a lot of comorbidities like hypertension, diabetes, they are elderly, they are so anyway prone to atrial fibrillation, and in any inflammatory state again can give rise to a lot of atrial fibrillation. So atrial fibrillations can occur in these patients, especially the sicker patients, and they reported to the tune of 10 to 15% in patients who are in ICU setups and really sick. So atrial fibrillation can happen whether it is a manifestation of COVID or it is a manifestation of the disease spectrum, and the pulmonary manifestation of COVID is difficult to say.
Right, thank you very much. I'll ask Neeraj two questions which are also related to the extrapulmonary manifestation. Should you investigate everyone for extrapulmonary manifestation, and if so, what should you do? And in patients presenting with extrapulmonary manifestation, when do you decide to use antiviral and anti-inflammatory drugs?
So again, for all patients, looking for any extrapulmonary manifestation will be difficult, but whatever can be done, like I said, KFT, the hemogram, the basic investigations including ECG, we do in all our patients. So if we are able to pick something on these lab investigations, or clinically patient has some manifestation which point towards any extra pulmonary involvement, then only we go ahead and do that specific diagnostic modality. So if a patient has weakness, has presented with weakness, of course we will go with CT. But of course CT head will not be done in every patient, just to look for whether this patient is developing something. So basic lab investigations and clinical examination will be key in picking up the extra pulmonary manifestations. And the second question was, when do we give antiviral and anti-inflammatory in such patients? So again, the role of antiviral is still controversial. So if a patient do not have any pulmonary involvement and patient is not requiring any oxygen support or is not deteriorating from cytokine storm type of view, so in those patients, of course, the role of antiviral is again not very clearly defined for extra pulmonary manifestation. So at the moment, just for extra pulmonary manifestation, we are not routinely giving antiviral to these patients. As far as anti-inflammatory in form of steroids are concerned, if a patient has oxygen requirement, then only we consider giving steroids. But without pulmonary involvement, without oxygen requirement, we do not usually give steroids to our patients.
So I think it's important to look at the patient holistically, and just the presence of some extra pulmonary manifestation is not an indication to give remdesivir or to start giving steroids. There have been a number of times when you may have an incidental, a small patch on the chest X-ray. That itself is also not an indication for giving remdesivir. There are a large number of patients who are asymptomatic and in whom CT scans were done and were found to have patches on the X-ray which resolved on their own without any treatment. So the presence of lung shadows on the X-ray or the CT in a patient who's maintaining his saturation is asymptomatic is not indication for giving remdesivir or starting any anticoagulants. I have two questions for Dr. Uma again. One is, how are you managing high-grade fever in patients who are on home isolation? One of the physicians written that he has a problem that some of the patients continue to get high-grade fever who are on home isolation, and is there something special he needs to do? And the second question is the whole issue that has come up from a report from Hong Kong about reinfection. How common do you think reinfection is as far as COVID-19 is concerned? Dr. Uma Malhotra.
Yeah, good questions. So for management of fever, our major emphasis is use of acetaminophen or Tylenol. And there is some data about avoiding non-steroidals, and so we tend to avoid those. And also, cooling and ice packs would be ways to bring the temperature down. And so, second issue pertaining to reinfections. So I think we will, as the pandemic evolves, I think we'll have more information about this. As of now, there haven't been many clearly documented cases of reinfection. So what we know for sure is that people can continue to have virus shedding that can go on for months and months. So I think a lot of the cases that were initially identified as having perhaps a reinfection were probably just people continuing to shed viral RNA. And I really want to emphasize again here that this is not infectious virus. This is just viral RNA that's just taking its time to clear. And I was just looking at a report yesterday of maybe 2 patients who that have been diagnosed and thought to be, really, reinfections. But I think, it's not so clear. And, how long immunity lasts, we don't know as yet. Perhaps. So again, I think as we get more data, we will, know more about that as well.
Thank you very much. I think it's an important point that you made, and it's something that came up early in the course of the illness, that it was a lot of reports came from South Korea that there was being reinfection, and then it was discovered that this was just continuous viral shedding, which is a virus which is actually not infectious, but people keep shedding the virus from the nasal epithelial for a long period of time, and therefore may continue to be positive even for 6 to 8 weeks, but this is not reinfection. The report from Hong Kong suggests that there is a little bit of difference in the genomic material of the second positivity that they had from the first. We need more data before we can really comment as far as reinfection is concerned. As you rightly said, how long the immunity lasts, we're not sure. It's a big question, and I think only time will tell how long we have our own innate immunity in terms of being able to be protected as far as the virus is concerned. But I think it's important that currently data doesn't suggest that reinfection is very common, and we need more data before we really say that reinfection is something of a problem as of now. Thank you very much. 2 questions for Dr. Padma. One is, how common is viral encephalitis? And in the patient that you presented, could COVID-19 have been incidental as far as the patient was concerned, and the patient just presented with stroke?
Yeah, so I'll start with the second part of it, that in fact that's one of the things that we had highlighted in our case presentation as well, that are we looking at like what Dr. Neeraj said, that is it that it's an innocent bystander in a wrong place, wrong time, in that part of it is. But said that, we also have had several hypotheses which have been postulated and being linked, because they did find the viral signatures in the central nervous system as well. As far as now, we have some data coming from the autopsy series, we have some data coming from the neuroimaging. So this could be that there is, as we said before, that there is a direct viral onslaught. Like other viruses, that you do have arteriopathy, very well documented level 1 evidence is an arteritis arteriopathy with varicella zoster. It is known to cause a pediatric stroke. So is there a virus involving the artery per se, arteritis arteriopathy? It could be that it's a post-infective inflammation, which was also postulated, and you have this prothrombin thrombotic or a consumptive coagulopathy. You also have cytokine storm and the comorbidities and what have you, and also cardioembolic. So besides all these hypotheses, why did we actually say that there may be an implication? Because we did have large vessel strokes being reported in young people who didn't have any other comorbid conditions, who were reported, those who went home and had these strokes at home suddenly, just like you had this cardiac condition. So these were all those pockets of the reported cases, which then sort of implicated that probably there is an implication, and we now know that it just definitely involves the endothelium, and endothelium is the biggest organ we have in the body. So therefore it could be an innocent bystander, because we have this huge asymptomatic population where they could be COVID positive and also have this vascular event, and it also could be implicated. But I think more important take-home message will be that irrespective whether it's COVID, non-COVID, a blocked artery needs to be unblocked. So your treatment algorithms, whether it is COVID or non-COVID, should be time-sensitive. Time is brain. So our algorithms have to be there. That's more important as a take-home message, which should go. What was the first question?
Viral encephalitis.
Yes. So there have been reports of viral encephalitis. In fact, there was couple of cases which got reported from Texas, wherein there was this brain imaging also done, which was typical, which was acute hemorrhagic encephalitis, which was just common garden variety of viral encephalitis. And now we have autopsies which have shown these viral signatures which are there in the brain. So it has been reported, but in our series we haven't found it. So it doesn't seem to be that very common. So it seems to be, stroke seems to be more commonly seen for reasons more than one than encephalitis. Encephalopathy, on the other hand, is very common.
Thank you very much. So I think, as Dr. Padma said, you can have a wide variation as far as the neurological manifestations are concerned, and we're really learning more and more as far as the virus and the extrapulmonary manifestation is concerned. I have a few questions for Dr. Amboj. One is the role of antiplatelet drugs as far as COVID-19 is concerned. I've seen also often that some physicians actually put their patients on antiplatelet drugs even prophylactically when they have mild illness, with the belief that this may actually help to some extent. And the second question is the antihypertensive of choice in patients who have COVID-19 infection. There is this whole issue of not using certain drugs like ARBs and ACE inhibitors. And thirdly, should thrombolysis be preferred over PCI in acute coronary syndrome in COVID-19? So these are 3 questions for you.
Yeah. So the first one about antiplatelets, it's something, a very relevant question, because we know it's a prothrombotic state. And so most of the management has been on using anticoagulation rather than antiplatelets. And I think it's an excellent thing to have been introduced. We learned early in the COVID pandemic that you should introduce anticoagulants quickly because it clearly reduces the vascular and other risks of COVID. As for the antiplatelets, yes, if the patient has other indications, if he has established cardiovascular disease or he have multiple risk factors for cardiovascular disease, I would say we should start antiplatelet. Whether to give it for everybody or not is something which is not clear, and we are doing a randomized controlled trial on that. We're doing a trial with both statins, which also, as we know, have pleiotropic effects and may help. There is some hypothesis that it may help in COVID. So we're doing a double-blind randomized control trial on aspirin and statin. We've already recruited nearly 200 patients. So that is how we are managing aspirin in these patients. The second question was on use antihypertensive. I think if the patient is already on whatever antihypertensive, has to be continued. The initial anxiety or debate is more or less settled that there is no harm on continuing the RAS inhibitors, whether it be ACE inhibitor or ARBs. There are two excellent studies published in New England Journal which they clearly showed that giving these RAS inhibitors did not increase the chance of having COVID. And if you were on these RAS inhibitors, you did not behave any worse. Your disease outcomes were similar. In fact, it works both ways. I mean, actually, if you give ARBs and ACE2, actually reduces angiotensin 2 receptors. So there might be some benefits of upregulation of ACE2 also. So as of now, there is clear consensus that you must continue on ACE ARBs if you have been taking, and this need not be stopped. These are drugs which are very well known to prevent not only hypertensive complications, but they are also protective in heart failure and in generally in protective against atherosclerosis. So we continue them if patients are already on those drugs. And coming to the third question of revascularization of how do you treat your MI, this is a policy that will vary from institution to institution and depending on what setups you have. Yes, ideally primary PCI is what is preferred in acute MI management, but given the chances of delay in testing or preparing your lab or having the adequate PP in your cath lab, it is a pragmatic approach to thrombolize quickly so that you don't waste your time, because the emergencies are well equipped to handle COVID patients. So what we do is quickly thrombolize them and then follow what is called a pharmaco-invasive strategy. So you thrombolize and then do an angiography subsequently and do an intervention as and when needed. So I think the pragmatic approach is pharmaco-invasive right now, but if you have an equipped lab which can take up patients without delays for primary PCI, that is the ideal choice.
Thank you very much. So I'll have 2 or 3 questions for Neeraj. One, of course, is if you have a patient with fever and unexplained diarrhea, should we suspect COVID-19? And how will you diagnose it? Is there a role of taking a rectal swab? And how important is it to isolate patients with extrapulmonary manifestations only who have a normal chest X-ray?
So the first question, if a patient present with fever and diarrhea, so in current situation, you should suspect patient for COVID-19, and whether you want to test through antigen test or RT-PCR, depending on what is available with you, that should be done. There is no role of rectal swab, at least as far as our testing policy is concerned. We are not using rectal swab for testing such patients, and how useful that will be is again a matter of debate. So I will suggest we stick to the conventional RT-PCR technique of swab, and that should help in most of the patients. And if a patient is SARS-CoV-2 positive, then definitely that patient has to be isolated even if he or she has only extrapulmonary manifestation, because these patients are infectious and they should be treated as infectious only. So these patients should be managed only in COVID designated area and not in routine area for safety of others and other healthcare workers.
So I think 2 very important points. First is, even if a person has extrapulmonary manifestations, he may still be shedding the virus from his upper airways, and therefore is infectious and needs to be isolated. And in most of our patients, and we've had 1 or 2 patients who actually surprised us, who presented with just with fever and diarrhea, your RT-PCR invariably would be positive. And in one, although there were no respiratory complaints, there were florid change on the CT scan. So just the fact that if they have diarrhea but don't complain of respiratory symptoms does not mean that they cannot have COVID-19. In the pandemic situation, you must test them and rule out COVID-19 infection. That is an important issue. We'll now have our final, we just have quick questions and then I'll ask the panelists to give their final comments. So I have 2 questions for Dr. Uma. One is, how often are you using anticoagulants at the time of discharge in your patients? And is there a role of the newer oral anticoagulants in managing patients with COVID-19?
Yeah. So we're not routinely discharging patients, with anticoagulants, unless they had a complication like a venous thromboembolism that required continuation of anticoagulation. And what was the second question?
The second question was, how frequently are you using the newer oral anticoagulants in managing these patients? Or are you?
Yeah, we're using, just as we would use in any other patient.
Okay, fair enough. So I think the take-home message here is very important, that all patients are not to be discharged on oral anticoagulants. You may do a risk assessment at the time of discharge, and if there is a higher risk for venous thromboembolism in the form of obesity or being bedridden or less mobile, then you may consider giving oral anticoagulants. But as a routine, one is not really recommending the use of oral anticoagulants in all of these patients. I would now have 1 or 2 questions, basically first to Dr. Neeraj, because there are 1 or 2 interesting questions. One is on favipiravir. How safe is it, when it should be indicated, and can it be given in pregnancy?
So again, the evidence for use of favipiravir is very, very limited. So whether it's effective in SARS-CoV-2 infection is again a matter of debate. So at the moment, we are not using favipiravir. None of the national guideline recommends its use. So I suggest we should not be using it without any indication, especially in pregnant patient where the data is limited. So my take on that is, at the moment, favipiravir should not be used in routine practice.
Okay, I would also really say we are not really recommending the use of favipiravir because the data is not that strong. The data for the drug, which is basically a drug which is approved for influenza, for H1N1, is not that strong. And the papers that have come in COVID-19 are not that robust enough to say that it is a useful drug for COVID-19 as of now. So we are not routinely recommending the use of favipiravir in even mild cases of COVID-19. We need more data as far as this is concerned. The other questions which have come, which I think also I can ask Neeraj, is what is the use of anti-inflammatory, non-steroid anti-inflammatory drugs like indomethacin? Dr. Uma Malhotra did mention that to some extent. What is your experience? Are you using other drugs besides paracetamol for the management of these patients?
No, sir. Over last 3 months, we never have used these anti-inflammatory measures apart from the steroids, which we give as and when indicated. The role of indomethacin or other anti-inflammatory drug, at the moment, we don't have evidence, and we are not using it routinely in our patients.
Okay, Dr. Amboj, if you had a case who had just a high D-dimer level and was on home isolation, would we advise anticoagulation?
Yeah, I think it would be prudent if it's more than 2 times the upper limit of normal. It would be prudent to start anticoagulation. Anyway, anticoagulation is 3 dosages are, one is prophylactic, one is intermediate, and one is full dose. So in patients who have mild disease, more than mild disease, you should start them with what is recommended 40 milligrams once daily of enoxaparin. But if the D-dimers are higher, we could step up the dose, and if it's recommended that if it's more than 5 milligrams, then we give full dose anticoagulation. So if the D-dimer is more than 2 times higher, I would suggest that we start anticoagulation, because that's one of the strategies. Again, not very definite data, but from observations, it's clearly being shown that anticoagulation is helping in the management of of COVID-19, given its prothrombotic condition, which can trigger vascular events and even pulmonary embolism, stroke, or MIs.
Okay, so you have to look at it on a case-to-case basis, because D-dimer can be elevated in a number of other conditions. So you must evaluate it properly. But knowing COVID-19 and the fact that it's a prothrombotic disease, one should have a low index of suspicion. And if you are suspecting that the D-dimer is because of you must consider starting at least prophylactic low molecular weight heparin. Neeraj, do you think ferritin and CRP correlate with disease severity, and should you look at these parameters alone and decide on giving steroids or treatment for cytokine storm?
So in the interim data, I had shown that the inflammatory markers like IL-6 may be raised in patients with comorbidity, and same hold true for serum ferritin and CRP. So just if you look these markers in isolation, so that would not be a good idea to use for deciding about the use of steroid in such patients. So the best thing would be to look the patient in a holistic way, whether the patient situation warrants role of anti-inflammatory or not. Sometimes we have tendency to start steroids right at the start, and the problem with that, a body requires little bit of inflammation to control the infection. So if we suppress the inflammation right at the start, then patient may later land up into a cytokine storm type of thing. So it's very prudent to use it when the patient lands up in moderate type of disease, or which is early sign of, say, patient is going the inflammatory response is going out of control. That should be the indication in the form of increased oxygen requirement, or the clinical situation of the patient is getting worse. So just based on inflammatory markers raised, we should not start patient on steroids.
Thank you very much. We are almost running out of time. I'd like to ask Dr. Uma if she has any last comments or take-home messages that she'd like to give to the audience as far as the extrapulmonary manifestation and their approach that they are following in Seattle is concerned for COVID-19.
Yeah, so a few points. So one, I want to emphasize the heterogeneity of the disease presentation and disease course. So just reiterating that it's really important to look at the clinical scenario along with the lab parameters as you decide, what treatments to use. So even, severe disease may be very heterogeneous. Not all patients have a cytokine, syndrome. So paying attention, to all of those parameters. And second, especially in terms of extrapulmonary manifestations, I want to emphasize that to remember COVID, but also remember that COVID can be a distractor as well, because we had a patient recently who presented with hemiplegia in the setting of COVID, 2 weeks prior, and actually, ended up having a brain abscess. So don't be distracted by the diagnosis of COVID, especially in the middle of a pandemic when, a lot of people may be positive. And then finally, one take home I want to say is, try to enroll patients in, well-designed randomized clinical trials, so we can have, good data on what is efficacious. So example, plasma, in the US, we have had thousands of people treated with plasma, and we still don't know whether, it provides any survival benefit. So do the best to enroll patients in, well-designed trials. Thank you.
Thank you very much. I think what you said in the end is very, very important, because we are really having a lot of treatment strategies which are being sort of given to these patients, but without enough high quality data in terms of their efficacy. And that's leading to a lot of confusion, and we need good quality randomized trials to be able to resolve these issues, whether it's the role of plasma, whether it's actually the role of remdesivir, or even anti-IL-6 drugs. We're not very sure how effective they are. They got emergency use authorization because of the pandemic and were tried out without the robust data that should have been there. So I think it's time that we also started gathering the data one way or the other. The first principle of medicine is to do no harm. Just that we should not really be doing any harm to our patients based on a sort of a panic reaction. Thank you very much, Dr. Uma. Now I'll ask Dr. Padma for her last minute's comments from the neurology point of view and the extrapulmonary manifestations of COVID-19.
Thank you, sir. So, since we now know that there's a spectrum of neurological manifestations, what I would say is that COVID or non-COVID, when you have a neurological disease, they need management as they deserve. When you say stroke, time is brain, so you need to have your algorithms in place. Just because they're COVID positive, it doesn't mean that they don't get the treatment that they have to get. That should be the take-home message. Whether it is an acute ischemic stroke, you need to do thrombolysis or endovascular treatment. You have protected code stroke mechanisms in place. So use that and treat them, whether it is encephalitis, encephalopathy, or a GBS, what have you. So those managements should go on, COVID or non-COVID, with some protection there so that you're protecting yourself, the patient, the caregivers, and the infrastructure. All these are well laid out. So that should be the message, that do not ignore the condition just because there is a COVID positivity report and then they just go on to a confined area and this is not taken care of. That should not happen.
Thank you very much. So I think a holistic approach is very important, and you need to look at the patient as a whole. And remember that, as was mentioned by Dr. Uma Malhotra also, that COVID at sometimes can be just an incidental thing and it may lead you down the wrong path. Ambuj, for your comments.
I think, sir, most of it has been summarized as Dr. Padma took away the cardiologist's adage that time is brain. It's actually time is muscle is what we used to use. So we must not, we have to be alert. We have to give our patients the best care despite the pandemic. And as far as the cardiac manifestations and COVID are concerned, it's been well summarized by Neeraj. So it could be three ways. It could be causal in some cases. In severe cases where of COVID, you can have cardiac manifestations as part of a systemic illness, or COVID could be a trigger for cardiac diseases like acute coronary syndromes, because acute coronary syndromes are known to be precipitated by prothrombotic state and inflammatory state, and we know very well that flu influenzas have been followed by acute coronary events, and that's why we give the flu shot to all patients who have high risk of atherosclerotic cardiovascular disease. So all patients who have had COVID, we have to be careful for secondary cardiovascular events that may happen. So we must make sure that they are on secondary prevention for cardiovascular disease as they deserve to be. Or sometimes the COVID and CVD can be just coincidental. So all the three things, causality, trigger, and coincidentality, may happen with COVID and cardiovascular disease.
Thank you very much. I think important points made. Neeraj, for your final comments.
Yes, sir. So it's time perhaps that we look COVID as a holistic multisystemic disease rather than just an isolated pulmonary. So I will say chest versus rest discussion should not be done. And as a matter of fact, the manifestation may entirely be different from what initially it was thought of. So it's time that we take this patient as a whole, and the best part is that the management of whatever extra pulmonary manifestation these patients have is according to the existing guidelines. There is nothing new that needs to be done in these patients. So whether they are kept in COVID area, the whole algorithm which is being in place should be followed for the best use and best outcome of these patients.
Thank you very much. So I think what we've highlighted today is the importance of looking at the patient completely, and the fact that in this era of COVID-19, you can have patients who may have some extrapulmonary manifestation, which are very important, and we need to keep that in mind. It's also important to remember that many of these extrapulmonary manifestations can lead to what we call post-COVID sequelae. It's not only the lungs, but it can be the heart, it can be the central nervous system, and therefore our overall strategy now is going to be also to manage these patients in the long run in terms of rehabilitation, in terms of what else we can do as far as COVID-19 is concerned. So as we move along the path of managing these patients, the long-term management of the sequelae of the extrapulmonary manifestation of COVID will also become an important issue. So we can have lung fibrosis, but we can have also cardiac dysfunction, which can be chronic, neurological dysfunction, and therefore it's very important for us to really follow up these patients again to see for the long-term sequelae as far as the manifestations are concerned. So I would just like to conclude by thanking all the panelists, and especially Dr. Uma Malhotra, who stayed up in the middle of the night to be part of this team. I'm really grateful to you for your help, and thank you very much for your inputs. Really appreciate that. And again, thanks to the two presenters, Dr. Ayush Agarwal and Dr. Deepti, for doing a wonderful job, and of course to Dr. Neeraj for covering the whole topic in an excellent manner. So thank you very much for all those who joined in, and we hope to see you next week with another area that we will cover in our National Combined Grand Round. Thank you.